Speech is a powerful tool, and it is the ability to express a lot in a few words. Welcome, students, to a presentation on phonetics in prosthodontics, and these are my contents. As you know, a good speech is a reflection of education, careless speech is an indication of irresponsibility, and a faulty speech is a handicap proportionate to degree of speech incapability. And I'm sure as students, you know the importance of all this. As the definition goes, speech is an expression of or the ability to express thoughts, feelings by articulate sounds. So what is phonetics? Phonetics is defined as a branch of linguistics dealing with the study of speech, the production, combination, and representation by written symbols. So what is the importance of speech? Speech sounds are commonly accepted human voices, which are linguistic and communicative significance. Speech is the key to communication. So that's the most important thing regarding speech. And it has got anatomic and functional components. Being this a prosthodontic presentation, I will not be explaining or delving deep into the anatomy or the physiology of speech, but I'll be just breezing through these slides for your information. And as you can see, the speech anatomical components are composed of the nasal cavity, the oral cavity, pharynx, the larynx, the vocal cords, the trachea, the intercostal muscles, and the lungs. All these play a major role in producing the sounds you hear. And what are the functional components of speech? They are the respiration, phonation, resonation, articulation, and the neurological components. So what is the mechanism of speech? As I told you, I will not be delving deep into it, but still breezing through it. Aspiration of the air from lungs is important, as well as the inspiration. So the way the air goes in and goes out, that controls the speech and it modulates it. And it causes vibration. And that's vibration in the form of words, letters, we call it phonation. So the expired airs from the lung flow through the trachea, the larynx, and vibrates a soft lining called the vocal folds or the cords to give the sound. And the minimum subglottal pressure and the pressure below the V for vibration of vocal cords is 7 centimeters of water. And the pitch of the voice is also depend on the rate of vibration. Of course, the passage from the nose to the trachea plays a major role in producing these sounds. And it is the resonance or the amplification of the air column between the vocal cords, pharynx, and the oral cavity and the nasal cavity that gives this. The raw sound produced passes through the closed chamber and it is then amplified and filtered. The velopharyngeal sphincter controls the contraction of the soft palate and helps in the resonance of the voice. Articulation is caused by the sound produced in these vocal folds after filtration and amplification. And there are active articulators and passive articulators. Active articulators are the tongue, the lips, soft palate, and the mandible, while the passive ones are the teeth, the alveolar ridge, and hard palate. So you can see like how the teeth and the ridges and the palate come into the fray. Now, that is importance of complete dentures and how it affects phonation. Then there is a neural integration, and the speech is mainly integrated by the central nervous system. These are the main areas of the brain which you are already aware of. And a brief through the nerves, the cranial nerves involved in it, the trigeminal, the facial, the vagus, the hypoglossal, and the nerve supply of the pharynx and the arterial supply to vocal cords play a major role. Anything affecting all these will affect your speech. So what are the factors related to development of these skills? So developmental sequence of speech, sound, your intelligence, hearing loss is if you don't hear sounds, how will you produce sounds? So that explains in differently able persons who cannot hear. Impairment of the motor skills, of course, that affects your tongue and other things. Control of the tongue is very important. Speech, language, disability, and of course, the psychosocial factors play a major role. And you know the vowels, the consonants, and the combinations which produce all the sounds. And the consonants can be again divided into the sonants or the voiced ones and the surds, the voiceless ones. So we're coming to the major part where prosthodontics is concerned, that is the plosives, the fricatives, the affricatives, and the like. What are these plosives? They're explosive sounds, which is produced by pronouncing P, T, B, like that. So when two lips produce explosive sound, it becomes P. And if it is alveolar, it is T. If it is velar, it is K. So these are like, it has got an explosive component. So that's why it's called plosives. Then we have the fricatives, which are the th, the z, sh. We have the affricatives, which is the tis in cheese. It is a friction. It's a combination of the plosives and the fricatives. The nasal ones, which is M, M. So anyone which are close, we have a common code. You know how the nasality of your phonetics is like M and the N's. The flexing the tongue backwards. It gives a that ones. Then we have the laterals. The body of the tongue is raised and they're close to the right or left, which is L, ill, like that. And we have the approximants, which is the consonant sound similar to vowels, W and the J's. So this can be classified as the bilabial sounds, the labiodental sounds, dental, alveolar, postalveolar, retroflex, palatal, velar, uvular, pharyngeal, and the laryngeal. As I told you, the bilabial sounds are happening because only between the lips, the upper and lower lips. And these are the P's, the B's, and the M's. So I want you to produce these sounds while you're reading or following me so that you know that how these sounds are produced. So let's do it again like the P, bilabial B. So only the upper and lower lips are contracting. Then we have the labiodental F and V. These are very important sounds. You will come to know why these are very important. So the F and V we regularly use to check the position of the anterior teeth. And this happens when the vermilion border of the lower lip contacts the incisal edge of the upper anteriors. Or we can put it in the reverse manner, where the upper anterior edges contact the lower lip, especially the dry wet area. That's called the vermilion border, of course. Then we have the lymphodental sounds, which is the th, where the tip of the tongue is between the upper and the lower teeth. Then we have the lingo-alveolar contact, the T's, the D's, and N with the tip of the tongue contacting the anterior part of the palate. With the lingo-palatal contact, with the tongue and the alveolus form the controlling vowel sh, z, and all that. With the lingo-velar contact, with the tongue slightly raised towards, it's the K's and the G. So coming to the bilabial sounds, let's see, as already explained, you can just rehearse with me the B, B, M. You can see that only the upper and the lower teeth are contacting. And if the teeth are not contacting at the right position of the lower lip, the sounds will not sound like them. So that is a problem with these things. Again, the F and the V, very important. As I already told you, using these sounds, we decide the anterior position of the upper teeth. So it has to be correctly positioned so that the patient can produce the F and the V sounds. If it is far too down, the F will start sounding like V. And if the anterior teeth are too high up, then the V will start sounding like F. Then we have the third sounds and like the this, that, these, and the those. T, D, S. These are the lingo-alveolar sounds, and a failure of the incisor edge to approach exactly end-to-end indicates a possible error in the overlap of the anterior teeth. We have the lingo-velar sounds. The velar sounds like the k, g, and nga, and all that. The thing is that these are sounds which has got no effect on dentures. Rather, this can be used for checking over extension of your upper denture along the posterior palatal seal areas. We have the vowels A, E, I, O, U. So these are all like the vela sounds, and these also help in checking the phonetic status in complete dental patients. So what are the factors that are affected because of faulty dental designing? So phonetics will be affected if these factors are not adhered to or these factors are affected. First one is vertical dimension, then the occlusal plane, the anterior-posterior position of incisors, relationship of the upper and lower anterior teeth, width of the dental arch, denture thickness and peripheral outline, palatal thickness and contour of denture, and finally the posterior palatal seal. We'll see one by one. The vertical dimension is very important. If the VD is too high, patient will talk as if horses are galloping in his mouth. Click, click, click. So we use the P, B, and M sounds to see whether they can give the plosives without any interference or clicking of the teeth. So that happens when VD is high. So what happens when the VD is less? So then the facial muscles will collapse and the clarity is gone and sound starts muffling. Silverman's closest speaking space is one of the most important phonetic techniques we use to check vertical dimension of occlusion. And it's a speaking method which is popularly used. So if the patient is unable to say S, Saraswati, Mississippi comfortably with the dentures on, then there is no speaking space. That shows that the vertical dimension is high. So this speaking space, Silverman's technique, is very important in checking the vertical dimension of occlusion. If the VD is high, then the patient won't be able to say S and sh. If the VD is too high, then the S and sh will be muffled, it will not be well defined. So Silverman's closest speaking space is a very important tool in denture fabrication technique. Then occlusal plane, if it is too high, then contact with the lower lip is difficult, speech affected. If it is too low, then the lower lip start overlapping the upper lip. Again, the anterior position of the incisors, as I already told you, the F and the V's will be terribly affected if it is too anteriorly. And if it is too posteriorly, the S's and the C's and the Z's will be affected. The relationship of the upper anterior to lower anterior teeth. So especially this happens in class 2 and class 3 relationship, where the mandibular positioning is different from class 1 position. And there will be some changes in the ch, j, s, z sounds. And the width of the dental arch is also important. A narrow arch means a cramped up tongue and less spatial volume inside the oral cavity and 40 T, Ds, Ns, and K, Cs. Of course, if the denture is too thick, the palatal thickness, the border thickness, then again there is loss of tongue space and decrease in the volume of the oral cavity. Again, the T, D's, the ch, sh's, the L's and R's will be affected. We are coming back to the same thing. Again, the palatal thickness and the contour of denture, which is very, very important because any abnormal thickness of the palatal plate is going to affect speech of the patient. So a well-adapted plate is very important, and any alteration in the thickness makes the speech indistinct and awkward. And posterior palatal seal, it is affected if it is quite thick because the posterior part of the tongue rises and contacts that part, and the thickness of that area, it affects. And as I told you, the vowel sounds, I, E's and all that, probably that get tampered if this part is thick. So you have to conduct some speech tests when you deliver a denture. So the phonetic aspect of denture construction is always checked during the wax trying. But the wax trying, there will be some thickness of the wax here and there. And of course, we use a temporary denture base. And that need not be the shape of the final. There will be slight alterations. But you start confirming from the trial stage and you engage the patient in random speech. The second test is to test specific speech patterns. So the process asks the patient to say B, 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 then F, B, ch, sh. So whichever part, which perspective you want to check, you have to ask the patient to enunciate that particular specific speech sound. Of course, these are the major speech sounds we ask the patient to enunciate: the S's and the sh's. The 66 ships sailed the Mississippi. Even I cannot pronounce that, to be frank. So all these are quite tough. So instead, you can use some local techniques. You can ask people to say Mississippi's Saraswati, Saraswati, Sayam, Sandhya. So I like that. You can use vernacular or the local languages, popular idioms, and all that. You can make the patient just engage them in casual talk. That is more than enough. For the T, D's, and hence and I, you can ask if you should say locator and tornado and all that. And of course, the Carnatic music sounds, tha, da, na. Just ask the patient. You can just ask them to say if it's a singer and all that. It'd be very easy to check all this. And the ch and the j's, we have the popular names: Joe, Joyce, Joel, George, Charles. You can ask the patient to tell all this. And if the patient's siblings or sons or boys, even any friend's name, you can just engage them in conversation, which involves names of these people too. And K, you can ask the patient to pronounce committee, convention. F and B, you can ask the patient fan, van, 55, and the like. Of course, paletograms are used when you want to take a graphic representation of the area of the palate. When the tongue contacts the palate, you get a graph like that, and which is used for speech studies and phonation techniques. And there is electronical recording of the palatogram too, which is called the electropalatography. And here the contact of the tongue with the palate is mainly recorded. The main importance and clinical significance is without the proper arrangement of teeth, placement of denture, speech will not be correct. So the most important aspect is the anterior teeth, especially. That doesn't mean that other parts are unimportant, but mainly the anterior teeth. Anything wrong there, the patient start lisping or mispronouncing. Of course, this becomes more complex when there is a oropalatal nasopalatal defect, and we give obturators, and this can be surgically corrected also. But if it is not surgically corrected, then it's onus of the prosthodontist to give an obturator. And when you give an obturator, shape of the palate is very important because that decides the phonation of the patient. And there can be cases where the soft palate paresis or paralysis of the soft palate is there, then you have to give a lift processes. It's called the palatal lift processes. We're using these processes. We are literally lifting the soft palate and approximating closely to areas which gives these sound effects. So that's called the palatal lift processes. So students, I hope that you got a concept on phonation in complete dentures and it has benefited you. Thank you so much.